Technology to address neurological disease globally. I'm Camelia Rodriguez-Sackburn, and I'm with the Global Brain Health Institute. A special welcome to our Atlantic Fellows and Atlantic Senior Fellows for Equity in Brain Health. Hello, all of you. This series is a partnership of the Global Brain Health Institute and the Global Teleneurology Service. Just a few housekeeping items. The first is today's session will be recorded for educational purposes, and it will be 90 minutes. Those on Zoom will be muted until the Q&A portion of the program, and we ask that you just also mute yourselves for any background noise. Please feel free to share any questions in the chat box, and I'll be monitoring that chat box to make sure our speakers see those questions. We will share the recording after the program along with a quick survey. With that, I'd like to welcome our speakers from the UCSF Radiology Department, Dr. Bhavya Rehani and Dr. William Dillon Jr. Both are co-founders of Health for the World. Thank you for being here with us.
Thank you for the kind invitation. Nice to see everyone here. So let me just move here. All right. So we'll be talking about Health for the World, which is our nonprofit initiative in global health. The co-founders are Dr. Bill Dillon, who's here, me, and Dr. Ankur Parija. Dr. Ankur Parija is the Director of Inpatient Geriatrics and Palliative Care at Stanford. So what is our story? So this is a picture of my grandfather's village in India, and it's in a remote location, and he was a tall guy with a smile on his face who used to bike around and help out the villagers and check on their well-being. Unfortunately, he had a stroke, and he was aphasic and had hemiplegia, and there were no doctors or speech therapists or physical therapists or any healthcare professionals in the whole village. And while visiting him during my high school time, I used to wonder that it is just so unfair that people in some parts of the world do not have access to just basic health services. I think the audience here can understand because all of you work in global health. So there are huge, health disparities. And he's not the only one. 400 million, according to World Health Organization, lack access to basic health services worldwide. And we believe in this beautiful quotation by Nelson Mandela: education is the most powerful weapon which you can use to change the world. And this is a picture of Dr. Maria. She's in a small hospital in Tena, Ecuador. She's a pediatrician, but as you guys know, that the physicians in the low resource communities wear multiple hats. The same person is a pediatrician, a neurologist, a radiologist, a primary care person. And she approached us and expressed the problem that there is lack of access to knowledge to save patients' lives. They're looking for knowledge which is reliable, open source, and given by experts in medicine. And wherever we went, all the doctors in South America, Asia, Africa, no matter where they were, expressed the same issue. And we believe that every doctor deserves to have access to knowledge to save their patient's life. So we created a solution. We created Health for the World. Health for the World is a 501c3 nonprofit organization based right here in Bay Area. And we use free educational and technological solutions to promote health in low resource communities worldwide. Before coming here, I was at Mass General in Boston, and I was working on some global health projects, but the issue was sustainability. We used to go and travel to countries and come back, and we did not, we were not able to create a sustainable solution. When you were there, you could help out, but when you come back, the things go back to the same. So we were looking for sustainability. And so when I moved here, I met Bill. Bill is the Executive Vice Chair of Radiology at UCSF and is a internationally renowned neuroradiologist and has traveled extensively. And he also believed, had the yearning to give back. And with Dr. Ankur Parija, who also grew up in India, we started Health for the World. So what do we do? What does Health for the World do? So our mission is to provide open access to the largest online database of reliable medical content. Apart from education, we use technologies. We believe that technologies can create sustainable solutions and can reach corners of the earth where doctors themselves cannot. So we use virtual classroom and learning management systems. For our education, we use mobile health, virtual reality, and we use machine learning. So what are the challenges? Since we work in low resource communities, the bandwidth is always an issue. There's always, the low bandwidth internet for live teaching. And I know many of you do live teaching, so you understand what I'm talking about. Language barriers, certainly because we work in 22 countries, across the world, and the languages are different, and we have to create culturally sensitive educational content. And the time difference. So right now, I'm sure there are doctors around the world who cannot join in because of the time difference. So that is always an issue. Coordinating with speakers nationwide, because we have close to, in fact, more than 100 speakers from different institutions nationwide. And so just coordinating with them to give lectures, and then creating a curriculum and measuring outcome metrics, because we want to do something which is actually impactful. And measuring that is important. So we'll be talking about the stories from 3 different continents, and Dr. Bill Dillon will take over here.
Okay, good morning, everyone, and thank you all for joining around the world and here in San Francisco. And as Bhavya said, my name's Bill Dillon. I'm a radiologist by training and a neuroradiologist. And yet we find that what we do here in San Francisco has applicability around the world, even in small resource poor areas. And so this was one of our motivating factors, to share that knowledge with others around the world. And here you can see a kind of a typical situation where you have, and this is in Cambodia, the floating villages in Lake in Siem Reap, in their lake, local lake. This is actually a village. These folks travel back and forth to school by boat and go to clinics by boat, but they have access to cell phones, as do approximately 95% of the world's population now. So the world is becoming much more available towards technology, and that's sort of the source of our efforts in Health for the World, that taking advantage of those infrastructures. So in Africa, we did a little survey a few years ago to the 3 continents to just ask the question, what resources do you have for education? And in Africa, we got a response from about 10 or 15 of the training programs, and we were focused basically on what resources do you have for radiology education. And their radiology residency is sort of typical, kind of European oriented. It's 3 to 7 years. Subspecialty training is offered in only 15% of the training programs around Africa. There are no neuroradiology fellowships at all. In fact, very few neuroradiologists in Africa outside of South Africa. And medical physics training, which for us is important because of all the resources that depend on physics, is offered in only 30% of the countries. And this is sort of rather typical. So the problem is that they have a CT or an MRI scanner in many of these countries, but they lack the education, and in many cases they lack the physicians to interpret or use those tools effectively. And in many cases, they lack the training to even use the tool safely. So in terms of medical physics training, it's a problem. And of course, the residencies that they do have, they're often very, very bare bones by our standards. Oops, let's see. Arrow keys. I'm doing the arrow key here. Should we try this? There we go. So with regard to Health for the World, this is just a screenshot of our conference room at UCSF during a lecture that I was giving. I think this one was given to the folks in Cameroon remotely. Here's a picture of the residents and some of their attendings, and here we are doing a screenshot of their group of residents while we're lecturing in real time, which was really quite an amazing experience for me to be able to chit chat with these folks back and forth, give a lecture, have their questions answered in real time. And the time zone, of course, is probably one of the biggest issues, that and the infrastructure in terms of internet connectivity. Here's a discussion with one of our pediatric colleagues, pediatric cardiology colleagues, who was consulting on a case of babies with congenital heart disease in Cameroon, and he's centered at Boston Children's. So this capability now exists throughout the world to be able to communicate with these folks in various countries from desktops. And this is just a real quick quote from one of the medical directors there in Cameroon, who says, "The residents and faculties here find the Health for the World lectures very uplifting. The new information about diseases and management options have helped us improve the treatment options for our patients." And that's wonderful feedback. Here's an example of the group of residents we lectured to in Tanzania, and also who started one of the very first interventional radiology programs. So we've actually brought some of our IR colleagues in to lecture and to give them sort of a hands-on training as well locally. There's a fellow from Oakland, Kaiser, who is joining this group soon in person, but also remotely lecturing. In South Africa, very similar kind of situation. Only 40% of the countries have specialty training programs. Medical physics offered in only half the countries. An example, a small clinic in Ecuador where there are no radiologists at all. They do have access to an MR scanner and a CT scanner. So the primary care doctors, and I believe there's a neurologist who goes down to help in this clinic. They brought the problem to our attention, and we asked them what they would like to hear about, and they said they would like to hear a little bit more about epilepsy imaging. So the problem is that they have access to a scanner or an MR scanner. They don't really have any radiologists at all to read the scans, and those who are taking care of the patients, neurologists and primary care doctors, have minimal training in that skill set. So here we have a picture of them during a Spanish lecture. We have several academics around the country who speak Spanish and have given lectures for us. And here's an example of one of my colleagues back east in North Carolina, former president of our society, Mauricio Castillo, who's an expert in temporal lobe imaging, and he's giving a lecture to this small clinic in Ecuador. And virtually the next day, one of the physicians there said that they were able to diagnose a patient with mesial temporal sclerosis. So they hadn't really understood that disease or its MR manifestations. So the impact has been very gratifying. We're currently in 22 countries. We've trained about 1,000 folks in various settings. We have about 100 leading speakers from top US academic institutions. We do a pre and post lecture test, and about a 70% score improvement is shown by these lectures. And we've had some 100 or so live workshops worldwide, and we're hoping to expand in different areas as well, and with hopefully with different colleagues. So these global classrooms essentially allow us to give access from world experts in the United States and other countries to these resource poor areas that you can see on the map. And here's just an example of some of the leading health experts from around the world who've participated with us. So I think we're at a critical juncture in the technology that allows us to bring expertise and lift up the health of folks in these various resource challenged areas. And I'm going to turn it over to Bhavya, who's going to talk a little bit more about the Health for the World Academy.
So has anybody checked out Academy website, or do they know about it? If not, we'll talk about it today. And so I would encourage everyone to check it. It is, let me just go here. Okay, so this is just a small GIF of how the website looks, and you can go and first you can type healthfortheworldacademy.org or healthfortheworld.org/academy. You can check, look for a topic. For example, in this case, it's myocardial infarction. The lecture will pop up, and then you can look at the video of the lecture. If you want to get a certificate and do quizzes to see how you are doing, you can do the quizzes. You have to log in, make an account. And then you can get a certificate, which looks like this, which tells you that you have attended the lecture and passed the post-test quiz. And there are close to 522 videos on YouTube and multiple lectures on the website. Apart from neurology, which is right here, and radiology, there are also multiple medical specialties, so close to 15 medical specialties in which the experts have volunteered to teach in different parts of the world, and all of these are online. It's completely free of cost. And as Bill mentioned, we have had leading experts from different academic institutions who have provided this reliable educational content, which was such a nice gesture. There's a YouTube channel. It's a good idea to subscribe to it, because then it provides you the updates about the new lectures. This slide provides a snapshot. So we have Disorders of CSF lecture by Bill. And I was just telling a story about it earlier today, that Bill gave this lecture in Kenya, and about intracranial hypotension and hypertension. And they were radiology residents who hadn't heard about this. And they thought this does not exist in the country. And after the lecture, they were able to make multiple diagnoses of this disease entity. So it always did exist, and but people didn't know about it. And I know, Riley, you have told me this before too, that people say that there is no multiple sclerosis, but when you go and teach them, then the cases of multiple sclerosis start getting diagnosed. There are other lectures in radiology from UCSF, Stanford, other universities, but there are also other medical specialties. On neurology, for example, this is a lecture on stroke prevention by Dr. Mark Fisher, who's the editor of Journal Stroke and is a neurologist at Beth Israel Medical Center at Howard Medical School. Intracerebral hemorrhage from Dr. Claude Hemphill from UCSF, whom many of you might know. He's the chief of neurology at the Zuckerberg San Francisco General Hospital. Lectures on pediatric stroke, neurointerventional trials. So it's pretty diverse. Brain anatomy. So you can see the diversity of the topics. Now, Bill talked very nicely about South America and Africa. So moving on to Asia, I'll talk about a story from Nepal. You guys are in global health, so you know how it is that patients get care when they go to the city. So when they're in their village, they do not have access to the doctors, and they go to the city to get treated. But the problem is when they go back, they are the same. They do not have access. So, for example, this patient had a stroke, went to the city, got treated, but when they go back, they do not have access through therapists, to speech therapists, to neurologists for secondary prevention. There's a high rate of 40% rate of recurrent strokes in these patients, and also a very high volume of morbidity and mortality. So how do we solve this? How do we solve this problem that people in remote areas of the world who do not have access to doctors and therapists, how can we help them? So that's where we use technology, and we came up with Health for the World Stroke app. So this app is free of cost. It's available on Android and app stores, on iOS stores. It has been downloaded more than 1,000 times in different countries, in 22 countries. And so it has physical therapy exercises. Dr. Erica Fish from UCSF was excellent. She helped us with making the exercises. So we videotaped her exercises. We converted them into animation videos. We had a very nice animator who converted these into lovely animation videos, which are very easy to understand, no matter what language does the patient speak. And then some of the stretching exercises are also in the illustrations format. So we have both the videos as well as the diagrams and the pictures for patients to understand. The good thing about these exercises were they were made universal, so that no matter what the deficit is, people can do this and do these exercises. And Erica did a great job, working with us and helping us out with the exercise modules. And there's a help me speak section, which is excellent, because if the patient has aphasia but they still can communicate and they want to say things, this is like a speech machine, so they can just press on the button and that will speak for them. So for example, if they want to say I love you, they can press on the heart. If they are feeling hot, they can press right here. So it has been a very effective tool for the patients to communicate with their families and their doctors. There's the reminder section, which reminds them about exercises, about medications, about doctor's appointments, about anything which they want to, which is super helpful. And then there's a machine learning-based conversational chatbot. So 40% of the stroke patients face depression. And there's a psychologist from Stanford who helped us create this. This provides psychological counseling to the patients and has interesting therapy tips and psychology tips to cheer up the patients and help them in their journey. It has links to inspiring quotes, videos, relaxing music, which can just help them when they're going through this tough disease, And then the good thing about the app is since our target population was in the remote areas, we have translated this into multiple languages. So there is Swahili for African countries which speak Swahili, Spanish, Nepali, French, Chinese, Filipino, so multiple languages, so that the patients can benefit from this. It is inspired and improved by stroke survivors. So I have an interesting story, because when we started this, we thought, oh, we got it all. This is perfect. Everybody's going to love it, And it was so humbling, because when we did this video conferences with patients, they were like, what does this mean? Or, this doesn't make sense. And, why do you have the spoon here? This doesn't suggest that I'm hungry. So we had to change it multiple times. We had to just come up with iterations and make it culturally sensitive and keep improving it. And we had we thought we might need just one iteration, but we had multiple iterations, more than 20, 30 iterations, just to make it actually helpful for the stroke patients and their families. As I said before, it's being used by patients, doctors, and health workers in 22 countries. It is actually being prescribed by the physicians and neurologists in different countries. We have done evaluation surveys of how the app is doing. And if you look at the survey, usually the family members answer the survey because the patient themselves have a stroke. The educational level is not that much because we are targeting the low resource areas, but more than 90% people said that they found this app easy to use and they felt confident using the app, which was important to us because this is a technology tool and it should be very, very friendly to the patients and the families. Here are some stories. This is Ataman Bahadur from Nepal. He said the app was very useful. I loved how every section was beautifully designed. As I'm quite forgetful, the app is totally taking care of my medication timings because the notifications pop up during the medication timings. And it's an alternative way to avoid going to physiotherapists because these people are in the rural areas. They have to travel for hours just to get to the closest physical therapist. This is Anjali Shah from Bangladesh. She said, I use the stroke app with the help of my daughter. My doctor has advised me to do regular physiotherapy, but due to expense, it was not possible for me. But with this, I was able to exercise regularly, and now I could move my hands and legs to some extent and manage to walk by myself, which means a lot for me. So again, people in rural areas who do not have any access can have benefited from this. This is Mr. Najoha Ibrahim from Cameroon in Africa. He said, I like the app a lot. Just by touching the screen, you can say something like, I want to use the bathroom. When I had my stroke, I could talk, but my family and the doctors could not understand me. If I had this, it would have been different. And I thank God for this. And he was one of the major, pioneers in using this and telling his villagers about the app. This is Dr. Thapa. He's the Chief of Neurology at National Neurological Alliances Institute in Nepal, in Kathmandu. He's very passionate about spreading the app. So he usually travels to the villages once a month to tell the patients about the app so they can use it. So our local champions, I think, are the key for actual success because they are the one who disseminate and who tell us how to improve. We were talking about cutting edge technologies. We talked about the virtual classroom, mobile health, now virtual reality. Virtual reality is a very cool tool for education because the anatomy is three-dimensional. However, the books are two-dimensional, and the virtual reality gives you a three-dimensional perspective of the human body. Here are some 3D virtual reality modules which are available on our website. You can also download the app and look at the modules. They're very basic right now because we have just started this process. This is a picture of a basilar artery aneurysm right here. So you can flip the organs around. If you want the augmented reality mode, you can download it in the app and project the module in the space and interact with it. We have used virtual reality for motor imagery for stroke patients. Actually, Erica told us about motor imagery in which if the patient is paralyzed or if it's called quadriplegic and cannot move, if they just imagine an exercise that leads to stimulation of motor cortex in the brain on functional MRI. So that is the power of imagination. And the recent research has named this concept motor imagery. So we use these exercises and this is a picture of a sandy beach in Carmel, which basically we told the patients to do some exercises of imagining on walking on the beach or, touching the sand or touching the water so that they could stimulate the motor cortex of the brain. All right, so on machine learning.
Thanks, Bhavya. And you can just imagine, if you're lying in bed, how wonderful it must be to be able to take a walk on the beach, even remotely and by virtual reality. So how do we sort of go to the next step to level the playing field? And we've talked a little bit about lectures and how that improves care, but it's sort of not enough, and so I'll share with you some interesting data from one of our fellows. You might have known or maybe you've met Andreas Rauschecker. Among other things, Andreas is an expert in artificial intelligence and machine learning as it applies to radiology. And he and his colleagues, when he was at Penn during his residency, have done some interesting work on comparing the improvement of diagnosis with artificial intelligence, in particular machine learning, which just to remind everyone is a method for automating data analysis by using various algorithms that iteratively identify patterns in data, and then the computer will learn from them. So I'm just going to share a couple of his slides, which I thought was very interesting. In this study, he looked at the ability of various individuals compared to the AI system to make a diagnosis, or at least to the top 3 differential diagnosis from a variety of MR pathologies. So he had, I think, somewhere on around 20 different pathologies on MR. The machine then was able to learn through an iterative process the patterns of those various diseases, and then he presented these to radiology residents, general radiologists who've already gone through training, neuroradiology fellows, second year towards the end of their training, academic neuroradiology attendings, and then compared it to the AI system. And as you can see here, this is the percent correct, the top 3 differential diagnosis in from those 20 to 30 cases. And you can see there's a gradual improvement, thank God, of neuroradiology attendings compared to general radiologists, proving that we do bring some value to the system. But as you can see, the AI system is not really significantly different from an academic attending, but you can see that it certainly improves over the general training of radiology residents and general radiologists. And then he also then compared this process based on common diseases, moderately rare diseases, and rare diseases. And as you can see here, the MR diagnosis of rare diseases, this is where AI really shines. And you can see that there's an improvement, particularly in the cross-hatched area, compared to radiology residents and general radiologists. So this is our sort of our standard. You can imagine folks out in a community that's resource poor, which we've already described, and just simply by having access to a computer system, they can improve the differential diagnosis dramatically over what they're normally trained with, particularly for rare diseases, and not have, even though they don't have access to a neuroradiologist. So this is a great potential, and I think you can just imagine this will be useful not only in imaging, but also in differential diagnosis of various diseases. So as Bhavya alluded to, we can use this technology to bring chatbots on the app. This is utilized for a stepwise approach to symptom management for both professionals and patients. An example here would be that the patient would say, I've got chest pain. Are any of the following true? The chest pain symptoms are acute. Is there hypoxia? Are there vital signs abnormality? And so the physician would start with this and be able to interact with the differential diagnosis. Now, with regard to Health for the World, I've been amazed at the tremendous volunteerism out there. This is totally volunteer driven. Nobody gets a dollar. We have somewhere in the 50 volunteer ranges from around the world of a variety of expertise, both medical, computer assistance, graphics, you name it. People, particularly young folks, are just so motivated to help out, and as I alluded to, a lot of the lectures as well. Here's just one example or two of medical students. Isaiah was a medical student here. He's now a radiology resident. He was instrumental in getting us up and running from an IT standpoint. And this is Simon, who is a medical student at UCSF and has helped us a lot with IT related such. And here's a couple other folks. This is a medical student in osteopathic medicine, and Francis is a medical student here at UCSF who's been helping us out. So we've had a great response for volunteers from both medical students as well as residents and many other folks who have helped us get this thing going. So it's very, very satisfying, I have to say, from that standpoint. Now, Health for the World has developed innovation hubs, and Bhavya, you're going to speak to this point, right?
So the question is, I think we have to all work on this in a collaborative manner because the challenge is so huge. And the question is, how do we work together? So as Bill alluded to, we are having humanitarian innovation hubs. This is basically partnership with academic departments, institutions, groups in global health who are doing excellent work, societies who are dedicated to this, so that we can collaborate and work together. The Innovation Hub is a group of people in the department or the society or the group which is interested in working with us. And there's a leader of the group who we communicate with. And then there are people like residents, fellows, medical students, postdocs, researchers, whoever is interested in doing this. And how we work together is our global education. And, for example, we were discussing earlier, we have neurology lectures, but we do not have multiple sclerosis. We do not have dementia. And I know the audience, many of the people through Zoom, and as well as Riley is a multiple sclerosis expert. So I think it's a good way to work together, in which we work on global educational projects in the areas which we serve. Research mentorship is when we match the research mentees in the developing world or the low resource areas with the research mentors in US. So for example, if there's a researcher working on dementia in Uganda, and he's interested in finding a mentor in US, and if the mentor is enlisted in our network, we can match them so that they can have so that the scholar can have some mentorship. We work on tech innovation projects together, the artificial intelligence projects and machine learning, which Bill mentioned about, mobile health, like the app which I showed you, virtual reality. And these days we have a diverse group and people are interested in different things, so these are some cool ways we can work together. And then there is health awareness. We make movies for health awareness in different languages, and some people are interested in that. So as you can see, there are a variety of projects, and depending on who we partner with, they're interested in something different, or either one option or multiple options. So what does a US-based innovation hub do? It's super easy. Just find topics in the curriculum for online education. As I said before, we have 522 videos, but we do have some topics which are missing. And then it's very easy to find those topics and work together on that. Invite professors to give those lectures. Usually we say about 4 to 5 lectures per year. Some people choose a month. So for example, there's a neurology month. And then, the lectures are given once per week, and they're given to our international audience. They can attend quarterly online meetings, which they find very productive because you can meet the collaborators from around the world. And it's usually very educational. And then, you can interact on social media and do things like that. So how does Health for the World help? So we provide access to online virtual classroom. We connect the hub to our international audience, around the world, so that they can train them, they can spread the education together. We organize a quarterly online meeting so that people can join in and meet our other partners around the world. We have a very strong software engineering team, as Bill mentioned, because we have a lot of tech support. So we have people who do everything, including just movie editing. The movie makers do that. They upload the videos on the website. So we have website developers who do that. They upload the quiz questions. So we have a really strong software engineering team who takes that, care of that for us. We have a social media team who coordinates the social media discussions and helps in dissemination of this important information. So that is also there. The time commitment is voluntary. I know everybody here is really tied up. And so we usually say about 1 hour per month, approximately. It's flexible, but that's what, usually people do. And some people are more passionate, they put in more time, and some people, spend around this much. So it's completely voluntary, as I said. The frequently asked questions which we have been asked about: what are the additional resources needed to partner with us? Nothing really, because everything is done through the tech support which we have. And how to get started? We just want to know a leader of the group who will partner with us so we can interact with them. So it's super straightforward. I already talked about the research mentorship program. There are a lot of mentees who are looking for mentors here in US. So that is very effective. We have been very lucky to have a very good advisory board. I don't know if you know Haile Debas, but he is one of the, he's the leader in global health. He is the founding executive director of UCSF Global Health Sciences. He's the dean of school. He was the dean of School of Medicine, the vice chancellor, and chancellor. He founded the Consortium of Universities of Global Health. And so his advice has been just extremely important in shaping this initiative, because he already knows what will work and what won't work, so that is super helpful. We have Dr. Dan Lowenstein, who's the provost at UCSF, and Dan is excellent. He's such an excellent educator and has been extremely helpful in shaping this initiative. Avinash is the digital marketing evangelist at Google. We have Dr. Kelly Skeff from Stanford, Dr. Claude Hemphill, who I already talked about, Remy for legal counsel, Jerry Kane, who is a computer science professor at Stanford, and he actually devised the Facebook like button. So when you like, he's the one who did it. And Stephanie Maris, who is the director of entrepreneurship at UCSF. We were in news recently for the impact, and last year we were awarded Organization of the Year. And have received multiple awards. But I think the main thing is the fulfilling journey of working with the doctors and patients in US and abroad. And we would love to work with anyone here. And here is our emails. This is my email and Bill's email to contact us, and would love to chat more if you're interested. Thank you so much. Really appreciate this. So any questions? Yeah.
Can you talk a little bit more about how the AI works for the imaging analysis and sort of how it's done,
Yeah, so Bill, both of us can work together on that. Yeah, so the question which was asked is, how does AI help with the image interpretation of the diseases? So there are multiple algorithms, and Bill, you can help me with this too. But there are multiple machine learning based algorithms. So for example, I'll take the example of disease stroke. And the question is there intracranial hemorrhage? So there is a machine learning based algorithm for detection of intracranial hemorrhage. That machine learning based algorithm will detect the hyperdensity in the brain and will mark that for detection of intracranial hemorrhage. But that algorithm has to be tested and should have sensitivity and specificity to compare with the human neuroradiology interpreter. So, and the algorithm is devised by a data scientist and a machine learning software engineer with the help of a neuroradiologist. So right now, if you just look at detection of intracranial hemorrhage on head CT, we have multiple machine learning based algorithms which have been devised in multiple academic institutions and also startups in the Bay Area and some international companies, which have been tested and which have been shown to be helpful for automatic detection of ICH in the brain. One of them is also FDA approved because it is so powerful in detection of intracranial hemorrhage in the brain. But the main thing is that, right now, the way it stands, it's a helpful tool for neuroradiologists. But as Bill mentioned, if there are no neuroradiologists or radiologists in parts of the world, this tool can be extremely impactful for detection of the hemorrhage in the brain. So this is just one example of how it is done.
Do you have to tell the program what to look for, or are you just, and is it only finding intracranial hemorrhage, or can it find a mass, can it find prion disease, can it find atrophy, and what is the pattern of atrophy? Or, you talk about how that a patient comes in, you don't know what they have, how does that get implemented?
Right. Right. So, yeah, so first repeating the question. So first of all, so the question was, can the machine learning based algorithm be used just for intracranial hemorrhage or diverse range of diagnostic pathologies like tumor, multiple sclerosis and other diseases? So the answer to that question is yes, but then the algorithm has, so how it works is you have to pose a diagnostic question to the computer. So for example, is there ICH or not? Or is there a multiple sclerosis lesion or not? And there are diverse machine learning based algorithms for each disease entity. And they have to be tested on a large data to make sure that they are effective. So yes, there can be diverse diseases diagnosed through machine learning, but each of them will require a different algorithm which has to be tested before it can be used. And Bill, if you want to say anything to that, that's fine too.
Well, I mean, first of all, I am certainly no AI expert. Okay, so this is computer science big time. But I think the important thing is that what you've just stated is the potential. That is, you have to have ground truth that that you use to for the basis of training a computer, which can ultimately potentially look at patterns of disease and get better and better based on the feedback that is given, either supervised or unsupervised, with ground truth as the gold standard. There are lots of projects going on in the radiology community. I'll tell you just one is an example, the diagnosis of pneumothorax from a chest x-ray, which often is an emergency. After a line is placed in the hospital at all hours of the night and day, and there is a challenge there, and they have to address these quickly. You might have to wake a radiologist up or call them from home or what have you. And so the ability of a screening tool like this to identify a pneumothorax for the folks in the ICU or what have you would be great. So that's one project that has been done recently here at UCSF with very promising results. Another would be, a typical example in this sort of scenario would be the chest X-rays that are done in remote communities looking for tuberculosis, and those have to be read. There's often not the expertise, so that would be a perfect example of training, with algorithmic approach to highlight those areas that on a chest X-ray that would be potentially worrisome for tuberculosis. And so those are sort of the problems that we do. Personally, I don't like counting MS plaques or looking for tiny metastasis for Gamma knife. These are sort of low-hanging fruit that really challenge the observation skills of a person. You're looking for needles in haystack. Wouldn't it be wonderful to just put these through an algorithmic approach, and the computer now says, hey, here's a new MS plaque that wasn't there on the last scan, or here is a concern for metastasis, and it would bring that to our attention, and we could say yes or no. So those are just some of the ideas, both from a diagnostic standpoint, from a screening standpoint. I can tell you that something like 40% of the papers at our last meeting were AI related. This is a huge area of interest and of academic interest in neuroradiology and radiology in general. The RSNA is upcoming. This is the Radiology Society of North America. Huge numbers of papers and presentations on the use of AI. So it's expanding. It also is used in the back end to improve the quality of images, to reduce noise, or to allow less radiation to be producing a quality image, a diagnostic image. So you'll see AI involved in all of the vendors, et cetera, that are producing images.
Yes, Riley.
First of all, thank you for this wonderful lecture, and congratulations on what you've achieved in terms of 22 countries already. I was curious about your dissemination strategy, so both within the countries that you're already sort of started serving and then sort of between countries. So how do you get the word out, and sort of what has been the more effective approaches there?
Yeah. So as far as within the country, I'll start with that. The biggest key is the local champion. If you find the right person who's so passionate about it, and you tell them that we really want to disseminate this, our aim is to help the people who need it the most. So we don't want to disseminate it in the larger cities, but we want to disseminate it in the rural communities. And if you feel up to that, then we'll partner. So that is very important to us. So I think the biggest success has been the local champions, and we choose carefully, because sometimes we just choose the right people, and we have been very lucky to find the right people. And as I said, I gave you the example of Dr. Thapa, who actually travels to the villages, and he used to do video chats from the villages with us, and we used to interact with the patients there. So that has been the key. And as Dr. Dillon mentioned about Albert Nyanga in Cameroon, who's the program director for the residency there, so all of these are our local champions who make it possible for within the country. as far as multiple countries, when we started with one, and we started from people we knew, and it spread very fast, and I would say by word of mouth, So when we started in Nepal, people in Bhutan came to know about it, and then the dean of the medical school contacted us. And so, they said, oh, we want to do this too. And then when we started in Kenya, then we got requests from, Rwanda and other countries. So I think, and there are, nationals and international societies who, who talked about this, that we are, working with Health for the World, and we found it very powerful. So we get a lot of emails every day from people, because I think, people speak about it. And the interesting thing which I have found about Local Champion is, because they are so invested in this, they talk about it not just, informally, but when they go and give a talk, they would say at the end or somewhere that, we've been taking part on this interesting initiative, Health for the World, and there are neurologists or radiologists in the audience from different countries who listen to that. So that is why we have been giving. When we started with people we know, but now we are working with so many more people, So that's, does that answer your question, really? Yeah. But anything else which we should ask? Okay.
Hi. I was just wondering, because you're working with 22 countries, and I assume probably more in the future, and you've got mostly US-based experts contributing to lectures and videos. So I can imagine that having culturally and context-appropriate content is easier when you're preparing a lecture, but how do you check or make sure that it's all right, and especially on the videos that are available for free online? Do you have a system, or do you have specific people checking, or are you asking different countries to have a look before you upload it? I don't know. Just wondering.
Absolutely. That's a great question, and the answer it is hard, because I think what makes our world beautiful is that it's so diverse, and even one country has so much of diversity. So we take, so the places where we do our online education, we ask them beforehand for the topics, what they feel would be useful, and what are the particular things in that topic which they find would be useful. We do like a short survey. Do you have a CT scanner, and do you have an MRI, or do you have interventional radiology, as Bill said, So so that's why we, so we kind of tailor it to our live audience. But since many of the countries cannot join live because of the time differences, they look at the recorded lectures, So we also ask them to give us feedback by email, whether they found that there was something missing in the lecture, or whether they found that it was not helpful, and should we do some other lecture, So the continuous feedback, and I think that has been very helpful for us to tailor the content, which is actually useful for them, The struggle is the language, because but we have, the videos have the auto translate features in 150 languages, so they can press on the subtitles and do the auto translations. And as Bill showed about there were some lectures which were done completely in Spanish, because the curriculum was designed in Spanish. So we sometimes do that also, but otherwise there are subtitles in different languages,
We have a question from Zoom that's been chatted in. So this is from Franklin Heng, and he asks, in countries that do not have radiologists for specific subspecialties, how would AI play a role moving forward? In US, for example, we still highly depend on human analysis because of our state of education and programs. However, in other countries that do not have the same level of education, how would the advancement of effective AI models affect the growth of radiological programs?
Okay, so I think both Bill and I can answer that question, because I think, so I'll go back to the example which Bill said about pneumothorax. I think that's a perfect example here, So if there is, for example, a critical care physician or just even a primary care physician who sees a patient and is worried about either pneumothorax or tuberculosis or something very basic or something very common which is seen there. They have a chest X-ray machine, but they don't have any radiologist to look at that. But if they have the algorithm or the software to detect it, so that will automatically detect the pneumothorax and say that there is 89% probability that this is pneumothorax, so even with no radiologist being there. So that is, so the answer to that question is, even though that there are no trained radiologists or training radiology programs, AI can fill in the gap with automatic detection. Will you want to answer to that?
Yeah. Well, I think this has incredible potential for, as I showed, leveling the playing field and bringing up the expertise that's potentially available there. I mean, so that's really the wonderful goal, not only in resource poor areas in our own country. There's only 5,000 of neuroradiologists in the United States. Most neuroradiology is read by general radiologists. And so, those of us who practice in this area realize that when people are referred in, there's often a discrepancy in the expertise just interpreting scans. So this has great potential to bring everybody up to another level. And for diagnosis, I think it's a tremendous potential in global health. You can just imagine what, prion disease being an unusual disease, but most folks have maybe seen one or two in their whole career, and so we're fortunate here because of our experience in neurology to see a lot of the variations here. But so that's an example where one could just bring up the expertise out there. So and then I think there's a question about how do we get, once these are developed, how do we get them to these areas that are not going to be able to afford, the software, and so that's a whole other issue. I think we're going to find that we're going to have a lot of help from various communities and foundations bringing those areas up to speed. So it'll be quite an interesting next decade for sure.
Just a quick question. Our network of fellows and senior fellows from GBHI are located around the world, and they have some incredible expertise in terms of their neurological skills and everything else. And so I'm wondering if there are opportunities for partnerships from folks like our fellows, our senior fellows who are based at universities across the world in other countries, whether they might be resource limited or not resource limited, just thinking about the lectures that you offer on the app and online and things like that.
Oh, I think, I'll let Bhavya speak to that, but we welcome everybody who's interested in participating for sure. It's obviously this is all volunteer driven, so we have folks who we have reached out to, people have reached out to us saying, hey, I'd like to participate, and it's very easy to do so. Literally at your desktop, you can give an online lecture that's recorded, that is viewable around the world. So it's I'm sure we'd love to have their participation. And I think it brings up a very important issue we talked about a little bit before, is that how do these various groups like ours, like yours, like we met someone yesterday, a radiation oncologist here, Benjamin Lee, who's doing something similar in radiation oncology, which you can imagine has issues around the world in terms of training. How do we work together? There's a lot of complementary aspects to these groups, and so I think to the point we were talking about is that having some kind of clearinghouse to see who's doing what and where would be very useful, and maybe that's something that already exists or could be developed through UCSF's global health initiatives.
Wonderful. And just a quick follow-up from the chat is from Jorge, was asking, to piggyback on that, how would people in the room or online reach out if they do want to get involved and do a lecture?
So our emails are right here. Our UCSF emails are here. There is also a contact form on the website. So if you can just go to the website and contact us through the contact form. And just piggybacking on what Bill said about how to partner with us, I fully agree with Bill. We welcome everyone who wants to work with us, and specifically with GBHI. We can also have a hub, in which we have a group of people who are interested in working with us, who help us coordinate with the GBHI fellows around the world. So having a partnership hub or something like that, and choosing what would be the most passionate project. Would it be education? Would it be mentorship? Would it be machine learning? Things like that. We can work on that together. So we can have, I feel that this, especially with the good work which GBHI is doing, we can have a really good partnership. And same with the global neurology.
We wanted to open it up for questions online. Other folks that may have zoomed in, any questions from you? We're working on unmuting everyone, and remind yourselves to unmute. As we do that, I'd also...
That's echo. That always happens.
We also have Mohammed online calling from Egypt. And I wondered if maybe you'd be able to share a bit about the work you're using Facebook data, and any reflections on that, and how, as Health for the World thinks about the work that they're doing, any lessons learned from how you use data and how they're thinking about using data as well.
Hello.
We hear you. Go ahead, Mohammed.
Yeah, okay. Thank you. Actually, it's a pilot project about studying the Facebook interaction pattern as a possible predictor for cognitive decline. So the idea is that we felt that Facebook that can replace the real-life social integration. And we thought to study the pattern in the last 4 years in the history of those who have been diagnosed with mild cognitive impairment, and see if we can come up through machine learning with an algorithm that can predict, based on the changes in language and comments and social network of the Facebook page, whether this can come up with an algorithm that can predict some cognitive decline related to the rate of decline in cognitive function or not. So it should be starting early next year, and we are now working on identifying the features we are going to isolate and identify and analyze in the work.
Very cool. And actually, that makes me think, again, congratulations, and Bill, on what you've been able to create. And the last time we spoke, I think so much has changed, and you guys continue to grow at an impressive rate. And I didn't realize how developed your app is. And so with some of the comments already and what Mohammed was talking about, so I'm curious about new directions or where you'll continue to grow. One thing that came up is this use of data. And as you have this app, and we now have this term of digital biomarker. And is this something, thinking about ways of diagnosis, are there new ways that you're thinking about moving in this direction, identifying what potential problems are, or other directions that you all are considering and excited about?
First of all, congratulations, Mohammed, on a very good project.
Thank you very much.
And I fully agree, because of the the data analytics portion, especially with the Facebook data which is being available. There's a lot of potential in doing good research. As far as where we want to go, I think the main areas where we want to spread is machine learning, because there's a lot of potential for machine learning in healthcare, especially in global health. Second is we want to expand our educational initiative, so that we can help more people, and we can involve and also help more people around the world. And that's why we are going through the partnership tracks, which we talked about. Specifically for the data analytics from the app, we have had some data scientists who want to work on the data to see if they can be an automatic, if using the iPhone, they can see how much improvement in mobility the stroke patient has, so they can record the movement on the iPhone video and then move it further, and then, do the physical therapy exercises and use the app, and then again record it, a few months later, And then using the algorithms, you can actually see whether there's any improvement in motion. And these people don't have doctors, so you can just say that, actually you're doing better. You don't realize that you're doing better, but you're able to move more as compared to before. So I think there's no limit how we can work on the data analytics and use algorithms to help our doctors and patients better.
And I think there's a preventative aspect to this whole thing. I mean, once you have a stroke, you have a stroke. But we'd like to be able to prevent strokes from happening either in this population or recurrent strokes. And so I think that would be a very interesting area that we could potentially look at. I think the whole machine learning thing is just wide open, and I was thinking that, we just have to get people involved who are experts in this area to ask the right questions and to be able to help us with improving the analysis, because it's there are an increasing number of people who are interested in the healthcare field who are also computer scientists, and I think that's a great amalgam, and I don't know whether that's something that you all have noticed as well, but it's certainly, I think a beautiful combination. A lot of kids who are interested in computer science. Is one of the most, Stanford, where we have some relatives who've gone there. It's the most popular, computer science is the most popular major now, outside of, exceeding English and humanities. So we have a huge number of people in the Bay Area coming out with training in this area, and they're interested in participating. We had a recent a meeting with the Harvard Club in San Francisco, and I was just amazed at, these are busy professionals now, how many people reached out to us afterwards wanting to help, just on their own. And so there's this huge area, I think, that could be tapped into in the Bay Area if they know about it. So.
I have actually more of a personal question. So in terms of, there are quite a few junior people on the line, as well as quite senior clinicians that I know. And when we think a little bit about how to position a career, right, to do meaningful work in academia, in clinical care, and then in global health, can you share a little bit about how you've structured your kind of global health and then academic balance, if there is a balance? Some people may be all the way just doing volunteer hours, as you said. Other people may be, employed by foundations. How does the academic person engage with global health?
So Riley, just let me clarify the question. Is it for the people, the professors who work with us? How do they balance that? Or yeah, in global health, yeah. So I can tell you about my personal experience. So when I started this, we started this, then there are some grants which people in, like in radiology, there's something called an RS and Education Scholar grant. So I applied for that when I joined UCSF, and which helped me, get some time to work on the global health projects. So, and I was talking to somebody at UC San Diego yesterday, and she's also having the same challenge, Riley, which you talked about. How do you balance your global health projects, your clinical work, your other research projects, and she's also going to apply for a grant. So personally, I think that having the grant was good. And one thing I just wanted to say was, when I was doing my residency and fellowship, what I just hated actually was that if I wanted to do something in global health, either I had to quit my job, quit my residency, or quit my fellowship, or just, take a long break, because there was not a good infrastructure to just tune in if you're really busy with life. And then when we started Health for the World, that was in my mind, because I wanted people who were working full time, who are crazy busy with what in their lives and their families, and they can just tune in maybe a few hours in a month and they have all the infrastructure which they need um, to do meaningful work in global health. And I think that is why we have had so many professors, and as you rightfully said, young faculty who we welcome, because this will be a very good thing for their career. They have the whole career ahead of us, but also the senior faculty who provide that very meaningful expertise because of just the minimal amount of time which is required to work with us. So I think the answer is grants. Another thing, I was a reviewer of the NIH Fogarty Center, which encourages people to apply in global health. And I was really impressed by how global health is coming up in different universities, not just UCSF. There were grants from all around the country, from different academic institutions, which we reviewed at NIH. So that's another way of kind of, getting some salary support to work on meaningful projects, But I don't know.
I don't have a whole lot to add other than, when you're starting out, it is hard, no question about it. But I'm just thinking that the resources that, or the infrastructure that Bhavya discussed, it's just ripe for academic questions, and so that's the hard part. I mean, really, when you think about it, like if you have a question and you want to ask it, who do you ask it to, and what sort of forum? Now there's these expanding forums that are available, and so that's that's one aspect that I think obviously that could form the basis of a grant, or preliminary report, or what have you. So I think there's great potential here. We haven't tapped it in at all. I mean, just doing the surveys around the countries resulted in publications that were very interesting.
I have, excuse me, a quick question just about the gaps that you see in terms of neurological care, neurology, with your app, with the offerings online. What other types of information would you seek to have available through the lectures, through the information that's posted? I'm thinking of the fact that within GBHI, for example, we have a range of neurologists, of neuropsychiatrists, of folks who are focused on palliative care, geriatricians. So I'm just trying to think if we're trying to kind of tap some of their skill set, building on my other question, where do you see some of the gaps in just the corner of neurology?
So we have a neurology curriculum online, which is very detailed with different diseases, and then it automatically tells us which topics have already been covered. So for example, in stroke, prevention of stroke has been covered. Diagnosis and treatment of stroke has been covered. Neurointerventional trials have been covered. I was talking before. We do not have dementia. We do not have multiple sclerosis. So there's still a lot to do. So I have a feeling that the GBHI faculty and fellows will find multiple topics. And even if one topic is covered, it might not be complete because somebody else might have a completely different outlook towards it, and especially if they're international, So, so there's an online curriculum which people can look at, and then we can also, and also, before I forget, we made a new speaker registration form. So because we were getting this is a very good question. We get this question all the time, that which topic should we choose? How do we know this topic is important? So there's a speaker registration form, which has a machine learning backend, which basically tells you, for example, if somebody logs in and says, I'm a neurologist, and says, I want to lecture maybe in March, and I want to lecture in Africa. So it lets you choose what you want to do, which part, when do you want to lecture? Do you want live or do you want recorded? And then it will tell, then the question pops up, which topic? And then it takes you to the topics which have been covered and which have not been covered. And so which helps you choose the right topic to give the lecture on, and then you can submit it. So it's very straightforward. So I think the GBHI faculty would really love that because it's very straightforward too,
Thank you. Do we have any final questions or comments, either here in the room or online? You can unmute yourself or chat in the chat box.
All right, well, thank you. Oh, hold hold on, we might have one.
One quick question. Is it possible for some folks, either in the GBHI network or other networks who do have skills and expertise to share, is it possible for them to share their trainings on the web, I'm assuming on your platform?
Yeah, absolutely. So if they already have lectures which have been given, they can send a link to us, and we also get this request from different national societies, like in Thailand and other countries. You know, we would be happy to post it and spread word about it. You know.
Fantastic.
Well, thank you again, and thank you everyone that joined online and in person. This is our final session for the Global Neurology Forum series this year. We'll be in touch about offerings for next year, but I think this was a great way to close out the year. Really terrific work that you all have championed, and excited to see where it goes in the future and how we can continue working together. So thank you again.
Thank you very much.